What's out, resource?
Cardiac arrest.
Yeah.
CPR started on scene.
Hello, resource.
This gentleman is a rollover RTC. He's got massive facial injuries. The risk of the face collapsing in is heightened. He's broken most of the bones in the middle of his face, so this is the critical point in this gentleman's care.
Full 7 o'clock, unequal pupils, dropping GCS. I suspect something catastrophic gone on.
The slightest movement causes excruciating pain for this lady. All right.
Bend down a tiny bit.
Feel a bit better now it's off.
Could have developed what's called a pneumothorax, where the lung starts to deflate down. That can be a life-threatening condition. Really, time is of the essence.
Breathe in and hold your breath. Breathe normally.
Do you want this trolley? Is that what you want?
Sue on the phone, what kit do you need? I've said the tubing, but she thinks you need an oxygen connector or something as well.
Hello, all service. Yeah. Okay, and what injury has he got to the left eye? No problem. No other injuries other than the head?
Left eye out of socket.
Okay, brilliant. Thanks very much. Thanks, bye.
Rollover RTC in an off-road vehicle. Query basis skull fracture, it's an isolated head.
Can we get on to ophthalmology and tell them that we've got someone who's got a traumatic eye injury coming in?
I'll put the trauma call out.
Got a 52-year-old gentleman who has been involved in a road traffic accident where he's rolled the car over. So the biggest concern is that there's a potential serious eye injury. We talk about life and limb saving, but life, limb and vision saving are as important. Hello, resource. Hi, Mark, it's Richard. Right, so, OK, so it's a big facial injury. OK. Yeah, OK, cheers, bye. OK, so that's an update. Can it be upgraded to a Cat 2? This man's got massive facial injuries because he's going to be a massively difficult intubation and facial injuries. His face is a mess. Cat 2. It just means we've got a rack, so we're going to need the difficult airway trolley and everything ready. So the risk of the face collapsing in if you've broken all the bones on your face and causing airway problems is heightened. So what we're planning for now is how do we manage someone who's going to need to probably be put to sleep to look after their face and their injuries with such a difficult airways.
It's an isolated head. The left eye's actually out of the socket.
We may actually just be sitting this gentleman up just to manage his airway if he's got a massive Le4 fracture or something. We don't want to lie him down and we've got to sit him up because everything's just going to collapse in. In terms of stopping the bleeding from anywhere, we're going to need some Foley catheters, some nasal packs. Can we get the can we get some nasal packs and everything in case there may be a point that we actually put this person to sleep and we have what we call a can't intubate, can't ventilate situation, which means that we can't see where to put the tube because his injuries are so bad. So then our last resort is to do a tracheotomy of the neck and go in through the front of the neck. Trucks have arrived. Right, it's going to be busy at the top end. So literally from half the bed down, no one further forward unless your anaesthetics, ENT, max backs up that end and need to be up that end. Off. No, we'll leave the trauma mattress off. We can.
How do you lower the table?
Yeah, okay, all right.
Right, cool. What we're going to do next, we need to move you from here to the trolley. Okay, so that's it.
So you just stay there, Paul. Don't try and move. We're going to do everything for you.
So move across and then hand over, Mark. Okay, thank you.
So Paul, do you think you can help us a bit? Do you think? Okay, left leg. Can you just bring your left leg across? Right, move your right leg across a bit. Okay, so Can you use your good arm? See how to stroke on this side. Put your arm down. You see where you're going to. Can you see there? Do you think you can start wiggling yourself across? Take your time. Take your time. Take your time.
Well done, Mark.
Oh, hold on, slowly, Paul, slowly.
Nice and
Right,
steady, Paul.
so just if someone just grabs his, just pull his overalls through, pull his
That's
bottom
it.
through, just watch that. Right, okay, come forward to me, Paul. Sit up a bit, 2
Sit
seconds.
up.
Sit up, sit up. That's it, lovely. Okay, Polly away. Paul, we've got you, we've got you.
Okay.
Paul, we're just going to lift you up the table. 1, 2, 3.
Fantastic,
Okay.
good.
Right, I'm going to give you one look just so you comprehend why I'm saying. Right.
Yeah, okay.
Okay, so this is Paul, 52. Previously had it about 10 years ago, had a stroke. Sorry? 50, I'm sorry, 50. I'm 52, you're 50. In a gator quad bikey thing, rolled it, max fax injury. On arrival, it's been GCS 15, based on the fact that we would presume the eyes are open. Extensive max fax nasal. A mouth opening's about 1 finger at best. He says there's no loose teeth, he says there's nothing free upside, but he's constantly bringing up blood. Otherwise, no other injuries we can find. Been free moving around. Cannulated, he's had 1 gram of paracetamol, 2 of morphine, some Damstron. Expect we've lost left.
Yes.
So when we know that, Paul, don't we? We think we've lost his left eye.
Okay.
But we can't, even though this eye will open, he can't see anything out that eye.
Okay, have you got any, can you see red,
I haven't
light
read
at all?
it, that's why I thought we'd get them to
okay,
us.
do.
Airways in there.
No, this is all full of clot. The teeth are not the best shape, but he says it's no. We've just been suctioning. Paul, you bring it up, you bring the blood to your mouth, don't you? And then when he's ready, he will bring it forward and spit it out. We haven't really tried. He's such a 90, been 96 and things.
Yeah, okay.
You can try. Yeah. But
I just,
we're back off and even.
So I think, thank you for that update, Mark. Can we bring Max Fax consultant? I need Max Fax and ophthalmology consultant here, please.
More than that, all right.
Is that, why can't he open it? Is that normal?
Pain.
It's pain. Okay. Okay. He's got a protracted jaw. He's got everything that fills up to a poor, difficult airway. No, don't put the oxygen on, please, because of that Max Fax injuries. Don't worry about the oxygen. His stats are fine at the moment. Okay, he's naturally bradycardic. We'll get the lining, get the bloods off.
So ophthalmology are aware?
This is the critical point in this gentleman's care. How we respond to Paul now will determine his survival chances. Yes, it is, absolutely. I've never seen that before. Could you order a trauma scan on him? Clearly, the immediate risk to Paul is with regards to his vision, but we also don't know how these injuries are going to affect his abilities to function. So we organised the scanning to identify the extent of Paul's injuries. Now we've assessed the gentleman, we can see that he's broken most of the bones in the middle of his face. So this part of the skull is clearly broken around here. And this is coming down now into his face. So these are his eye sockets here. And there's damage to the eye, as we already know. There's damage to the nose, which is sitting in the middle that you can't really fully work out. And there's damage to the base of the skull all around here. There's a lot of injuries and fractures there that will all need reconstructing and putting together after that. So this gentleman's care is very complicated. It's going to involve multiple teams. It's going to involve the neurosurgeons, the facial doctors, the ENT doctors, and the ophthalmologists to work out everything they need to do. We need to now take him to theatre and do a formal tracheostomy on him so that we're breathing through the neck whilst we sort out the face. So this is the first step in the care of Paul. This is not a quick fix scenario.
Hello, Royal State Resource.
Hello, Becky. It's Paul Hancock. I'm the consultant trauma team leader over at Stoke. I understand that you might have a patient over there who's potentially heading towards us. So there's a trauma transfer coming across from Leighton. It's a female car driver who's been hit by a van. Car's spun multiple times. She's got multiple rib fractures, a spinal fracture. And she's got an esophageal tear.
Yep.
Beautiful. There you go.
We'll get a trauma mattress on here then.
Patients who are transferred across to us are more complex patients. They've had time to deteriorate or other injuries to show themselves. In this case, the patient's got 3 sets of injuries, all of which can be life-threatening, life-changing. So we need to deal with them as quickly as possible. Really, time is of the essence. Trauma that's coming across, are we setting up in one?
Yes, do you want me to do it now?
Shall we? They're in process, so they should be here any minute now. The big concern with this patient is that she's got multiple rib fractures and a tear in her esophagus. Esophageal tears can be quite dangerous to the patient. You rupture, but you've then got the risk that stomach contents can release themselves and you can get quite nasty infections from that. Worst case scenario, it could lead to sepsis, which ultimately could then be life-threatening to her. Into number 1, please.
Oh, all right.
Happy to hand over?
Yep. She's in a small Suzuki Swift type car. She's been hit around about a 50-mile-an-hour impact.
Yeah.
She had to be cut out of her vehicle as well. The slightest movement causes excruciating pain for this lady in this area. Okay, the suspicion is in the esophagus.
Okay. In this case, the patient's got 3 sets of injuries to her esophagus, ribs and spine, and having that can create quite a complex patient to manage.
Can I have my head up? She's been on like a 10-degree incline, no more.
Told me when.
Potentially, they could have further injuries that we just don't know about yet.
I'm just going to have a little feel of her chest.
Okay,
that's fine. Yeah, sorry. So she's got tenderness on the right side.
Yeah.
Good. So I want you to breathe in and breathe out for me. Good. One more time. Oh, sorry, love. Sorry. Where's that? On the...
Yeah, just on that side.
So, oh, okay.
You did say there was 3 fractures there and 1 on that side.
Oh, okay. So she's got tenderness on the left as well, left and right. Yeah.
SATs are 89.
SATs are 89. Okay. So this is a new thing?
Yeah.
Okay.
I'm going to put some oxygen on you, sweetheart.
Okay. Yeah.
I'm just going to lift your head a little bit up.
We're trying to get ourselves up to speed as quickly as possible.
Can you just open your eyes for me? Good.
So our oxygen levels are lower than we were expecting. She could have developed what's called a pneumothorax, punctured lung, where the lung then starts to deflate down. And at its very worst, that can be a life-threatening condition. We're going to repeat some imaging and then we'll get a plain film, an X-ray of her chest. Hello, X-ray people, how are you?
Call from A&E X-ray staff base.
We've got a plain film that we just put on as a portable. She's in Resus 1.
Yep.
Diane. X-ray. Hey, Diane, big breath in for me. And breathe out, sweetheart. Paul, do you want to have a look at it?
Yes, please. Just looking at the first look at the images, big concerns that we had were whether there'd be a big pneumothorax or a big hemothorax, but we're not seeing anything that's on that image at the moment. At the moment, oxygen levels are improving, so we're going to change our focus and start to investigate any further injuries.
Do you want us to ring anyone and let them know that you've arrived here?
No, I told them to go home. They've been with me all day. My sister and it's been a rotten day. Started work 6 o'clock this morning. I have a carer in the community. Just finished my call. Coming back home, well,
Cardiothoracics are here. Perfect. Yeah. Point of concern at the moment is her esophagus. And then we'll get our surgeons and our specialists to review her.
I've requested a CT thorax with oral contrast. The first scan showed possible air bubbles around her food pipe or the esophagus, probably from the initial accident. Now she's going for a repeat CT scan of her chest. Now what we're trying to do is assess have you had a tear in your food pipe.
Okay.
But what we need to do is get another scan. We'll see a bit later.
So I've got to lie completely flat like this.
Flat with a bit of tilt.
Can I have a little bit more tilt?
I'll ask. I'm not the
Please.
spine doctor. All right.
Just a little bit.
We'll see you later.
Okay.
Okay, bye.
Thank you so much.
Okay. Good to go?
Yeah. The majority of these leaks are quite small. Yeah. If it's a big leak, then it might need surgical intervention. It's best to have a look at these injuries within the first 24 hours.
A couple of big sips, okay.
So the contrast that she's taken, she's swallowed, and that's an oral contrast. And really we just need to track with the CT where that goes, whether it's remained within the esophagus and gone into her stomach, or whether it's leaked out of any holes or tears within her esophagus, and then we'll be able to track that.
Breathe in and hold your breath.
So the thing we're looking for in trying to track is the contrast, so hopefully it doesn't leak out of the esophagus. And at first look at that, that looks to stay within her esophagus and into her stomach. I don't see it going anywhere else unless you do.
No.
Yep.
Looks good to me.
So what you can see there is that, I mean, that image displays it beautifully. That bright white there is the contrast. It is within her stomach, which is where we wanted it to go, where it should have gone. So it's quite reassuring seeing that CT at first look there. Being hit by a van at speed when you're in a small car obviously could create quite serious injuries. All in all, she's actually been quite lucky for what could have happened to her. She's been really lucky.
Hello, Royal State Resource.
Just juggling today. Should be all right in a minute.
No, it isn't. Sorry, it's a resource standby phone. Hey.
Paul, you don't have a pacemaker or any prosthetics in your body anywhere? Any metal plates or anything like that? No?
Paul was involved in a horrific accident where he was driving a quad bike, having had a significant craniofacial injuries. Unfortunately, Paul has lost the vision in both of his eyes, so he is going to be blinded from this injury.
Can you feel me touch you there? Yeah. So Paul, he is so kind and gentle. He works on a farmer's estate. He's just good fun. He'll do anything for you. And to take everything away from him is a big, big shock. What do you miss most about work then, Paul? Seeing everybody.
Can you see anything of me? Can you not see no red? Nothing? You can hear me voice? You can hear everything? From when he came in, he's doing 100% fantastic. He's strong. The willpower behind him is unbelievable.
Today, we are going to embark on trying to repair all his craniofacial fractures.
If we left him in the current state that he is, he will not be able to eat and drink normally. It will affect his speech quite significantly. He is at very high risk of developing infection in the brain. That would be life-threatening for him.
This is Paul's 3D model, and you can see that the impact was, and what has happened is that the force of the injury had such an impact that actually most of the face has been displaced laterally. He has broken his skull, he's broken his nasal bones, he's also broke his cheekbones bilaterally.
We have to make sure that his bones are put into the correct place for him.
We're praying for him to be able to speak again and just be himself as best he can.
My name's Kate, I'm part of the theatre team looking after you.
It is a major trauma surgery. It's going to be an operation that's probably going to be 8 hours long. And this operation is very crucial for Paul.
I think there's a risk of bleeding in terms of the brain itself, especially when you're doing the craniotomy. The risk of bleeding when you are exposing all the fractures. There's a risk of infection. We just have to be very careful, take our time. Yeah. So a lot of the risks are managed as you go along. So, Murli, we are ready to go, yeah?
Yeah.
Okay. Right. Now, this is the coronal flap, okay? So this is basically, well, I would say it's like doing a face-off, yeah? So we're just going to peel the scalp off the cranium, yeah? Okay, thank you. Good. So can I have a knife again, please? Handle it, thank you. Nearly there. Yeah, that's the maximum of it now. Okay.
Having sustained such significant facial injuries, we have to create the barrier between his brain and the rest of the face.
So this layer here, this layer is called the pericranium here, and it's a layer that is basically covering the bony aspect, and we're going to preserve that because that's what we're going to use to seal the brain. Yeah. This is the first fracture we're coming across now. This is like the top part of the skull fracture. So now the next thing is start getting access to the internal structures so we can protect them and then start moving the bones into the right place. Yeah. Okay, mark a pen, please. Thank you.
He will need a craniotomy, which will involve multiple specialities, and everyone will bring their expertise in order to get the best result.
Can't go any more lateral than that on this side, yeah?
Yeah.
So just waiting for the neurosurgeons. What he's going to do is going to do a craniotomy. So we need to decide the craniotomy access.
We need to open the head up to get to the brain and all the other fractures from inside the skull.
I don't know what's your opinion, but I think so that should be sufficient.
Okay.
Okay.
I think
He's got a fracture there.
Yeah.
Right. And that will then fix very well. Okay. All right. Thanks.
Start. You ready with flow seal? Got flow seal ready? Mastoids.
Yeah, everything's ready. Yeah, you got me.
You need to hold the head.
Okay. Sorry.
Okay. It's just underneath this drill is a big vein. All the blood that goes to the brain goes through that vein back to the heart. So if it bleeds, it can bleed a lot, very quickly. Okay. Firm, yeah? Come on, bite.
There you are.
McDonald's, please.
Paul has had a significant injury. His facial bones are not in the right place. The trickiest part is making sure that we don't damage blood vessels.
I'm trying to separate the brain covering from the bone. Now, because of these fractures, it will all be stuck down. Obviously, it is important to do this gently without damaging the brain or making it bleed a lot. If it starts bleeding a lot, we have about 2 minutes to deal with it. You want this to come out separately?
Well, if you can just pivot it. Okay, can I have?
I think that is now separate.
Can I have a house, please? Thank you. And then you can bring that as a separate fragment. Yeah.
Yeah.
Yeah. Lovely.
No, this is free.
I stuck it on soft tissue.
Right.
Lovely. Okay. Right. Yes. Thanks. Thank you. So we're just going to leave that soaking in iodine, and then we'll start working on the sinus now. Lovely. Unfortunately, part of the frontal sinus is within a bone that is very mobile. So we have to start stabilizing the fractures before we can start working on the frontal sinus. Yeah. Can we have the plating system ready, please? Yeah. Okay. So we need it on a tray on the side. Yeah. Okay. So we use titanium, and these are very fine plates, right? With screws. Yeah. That's predominantly the main way of fixing them. Yeah. The sizes of the plates and the screws vary in terms of the thickness and the diameter. Yeah. Okay. Can I have a stool, please? Thank you. So can I have 5 millimeters, please? 5 millimeters.
5 millimeters.
Do you want to come here, Craig?
No, it's okay.
Then the nasal bones are all in one piece, yeah? Okay. 5, quick.
Yeah, 5.
He's actually trying to do a very complex jigsaw. That's what it looks like.
Looks good.
Luckily, when bones fracture, they normally leave a pattern.
5 millimeters, please.
And you can actually get the bones in pretty much the right place.
Back to you, Joe.
So currently, we're in a position where we have done a transfer. So literally, the bones from ear to ear has been fixed, yeah? So that projection is right, okay? So now we're going to do the vertical projection. Okay, so that's right, I think. So basically, that's done. And the inner wing is done that. Yeah, it's done like that.
Oh, okay.
So it just needs to come up, yeah? Okay, 5 millimeters, please, thank you.
5 millimeters.
Okay. Okay, next. Should I do the cranium bit, yeah? We fixed his nasal bones, right? So the next step now is to sort the anterior skull base. He actually has got open fractures, from the nasal cavity, the sinuses, into the brain itself. What we have to do is we have to create a barrier so there is no communication from the outside world through the nasal cavity into the brain.
He is at very high risk of developing an infection in the brain. I'm going to take some of that bone from the cranium as a graft in order to plug this hole that has been created due to the trauma.
Okay, so can I have a ruler, please? Yeah? And a piece of paper, please? Yeah?
Okay.
Thanks, okay.
Right, run up there.
Okay, that's great, thank you. Right, okay. Yeah. So I'm just going to, I've got a template now, and I'm just going to use that to create a bone plug. Okay, can I have a mallet, please? Thank you. Just slowly, very gently, yeah? Okay, go for it. Yeah. Perfect.
Yeah?
Yeah.
You're going under the brain as well.
So this layer here, this layer is called the pericranium here. It's what we're going to use to seal the brain, yeah? Looks good. Looks really good. Yeah.
We managed to reduce all the fractures. We used a total of 170 screws to hold the bones in the right place.
Okay. Yep. Can I have the craniotomy, please? Fine.
That looks good.
Okay, another 5, please.
Once you get the underlying structure, then the skin will mold to the right place. It will take 8 weeks to heal completely.
Okay, so the next thing I need is, can I have a damp swab, please? Yeah, and then a, yeah, okay.
Yeah.
Yeah, so should we call it a day? Yeah? Yeah. Thank you very much. Yeah, done. No. It went very well. I think so what we wanted to achieve in terms of the surgery is exactly what we've achieved.
Paul will be able to carry on pretty much a normal way of managing in terms of eating, drinking, his speech. The only big issue with him is his loss of vision.
You know, we'll wait and see how he will try to cope. The family are fully aware of that, and they will be very supportive to him.
Hello, resource.
Won't need a filleting film. Check whether they need one, save you plumbing in and turning around. Proving to be quite a busy night for us. I've started at 4 and we've essentially been battered. And it's now 1:15. And we still haven't stopped and they're still coming in.
Hello, resource.
Yeah.
He's unresponsive. Okay, how long will he be?
Oh dear. It's Paul.
Didn't phone it as a trauma, but it's a 65-year-old who's fallen from standing, sustained a head injury. They're saying he's unresponsive, but he is maintaining his own airway.
5 minutes away.
It'll be 5 minutes.
Okay.
Let's just move that out of the way then.
So this is a gentleman who's fallen, sustained a head injury, and we're told he's unresponsive. But really, we need to find the cause of the unresponsiveness, whether it's something that's happened pre the fall and caused the fall, or whether this is something as a consequence of the fall. The unresponsive manner, we're setting up in 1 for him. So he's a fall from standing, and then a decreasing GCS ever since.
One pupil below. So yes, it'll be 6 points. Oh, I haven't signed it yet.
On your count, boss.
Okay, 1, 2, 3.
This is Gary.
Yeah.
He's had a fall about 7 o'clock in the evening.
Yeah.
He lives in a care home.
Yeah.
Care staff say he has been declining with them.
Yeah.
He's got a laceration just at the back of his head. We haven't had a proper feel of it. Can't get access to him at all. So when we've got to him, pupils are 7, left pupil is, right pupils are 3.
Yeah. Right. It's full 7 o'clock, declining condition,
7 o'clock,
unequal
yeah.
pupils,
Yeah.
dropping GCS. Oh, go on. Sorry. Would you mind opening that up for me? Sorry to be a pain.
The ECG, yeah?
Yeah. Sometimes patients arrive unconscious and we have very little information to go on about their previous conditions that they may have, which really can lead to a lot of detective work to try and find out as much information as quickly as possible.
Years on the blood thinning.
Yes.
Yeah. But it's been stopped.
When was that stop?
First by Soperol.
We'll need to get this gentleman through our scanner quite quickly. I'm concerned that this is quite a severe head injury. The man who's fallen from standing, he's got a GCS of 3, he's got unequal pupils. I suspect there's something catastrophic in his head. He has unequal pupils. There's a sign of pressure within the skull cavity, which is generally quite a late sign, and that's why I was suspicious that there's something quite nasty going on. So we'll need to get this gentleman through our scanner quite quickly. Have you got enough oxygen in that cylinder, boss?
Yes, I've got plenty in here.
With his age, it's easier to damage the brain and the blood vessels that surround it. If you take the skull as being a fixed size and the brain within it, as you get older and things shrink, one of the things that shrinks is your brain. So that if you were to impact your head and give your brain a shake, those vessels are easier to tear, which can create quite nasty bleeds within the brain. Is that at 20 you wouldn't think about it, but at 80 these can represent life-threatening injuries. Ready, steady, slide.
Yeah.
So the things we're looking for really will be the injury to his head that he sustained as part of his fall, how he's presented. I suspect something catastrophic gone on, but we'll soon see once the scan's done.
Oh, God.
Really, he's got a head full of blood. Massive amounts of blood in all the wrong places within his skull.
So the CT head, as you can see, is terrible. He's got a bilateral large volume subdural hemorrhage. There is significant midline shift to the right. There is subfalcine herniation. There's uncle herniation. It doesn't look very good brain to me. So.
The volume of blood that's within his skull, it's quite a large volume of blood, and that's really compressing his brain, and as that's compressing his brain, unfortunately it presses against some quite delicate structures around the brain stem, and those are the areas that have the kind of automatic features necessary for life. This is a life-threatening event that we're seeing here at the moment. His brain is just literally being squished. This is the event that will end his life, unfortunately. In this case, there isn't anything that we can offer that can change the outcome of it, which is just horrendous. But the difference that we can make in the end of somebody's life is keeping them comfortable, which ultimately, hopefully, makes a difference.
It's Lisa.
Hello, Lisa.
You alright if I do your blood pressure?
Yes.
How are you feeling today?
Fine.
Good, good. You've got this on here. Okay. Your buzz is just to the left of you. Okay, and then you've got your water, and then you've got your fresh juice. Alright? See you in a bit. If you want anything, press your buzzer, okay?
Oh, will do.
See you in a minute.
It's just the girls, the nurses are very good. Everybody is. They help me. I'm just looking forward to the bed when I get back home. Especially the days are all dragging.
I think because it's long days for you, you think a lot as well, don't you? I think if you were occupied a bit more, I think when we get the right place, you'll be a lot better. Yeah. You'll have your up and down days, but at least one thing, you smile still.
I know. Adrian's taking me out to the pub sometimes.
Yes. What's going through your head, Paul?
Huh?
What goes through your head?
Can't see.
Yes, I can't see him.
The top will be there.
Hello, will sit with us. Is she from a care home? Yeah. How long will you be? Thank you. Bye. So this is 100-year-old female. 5-6 minutes, they've said.
Basically, this patient is quite sick. Okay, everybody got the gloves on.
It's Chris Pickering. Pickering. Chris Pickering.
Hello, Royal Stoke A&E. There's a young lady who had fallen off of a horse.
Ow.
Can you feel me touching your toes there?
No.
Nothing at all?
No.
This could be devastating.
You're definitely in sepsis.
He could be dead within the next hour.
I just need to get a few treatments into him to save his life.
We had a head-on collision.
The big worry is uncontrollable bleeding.
And the critical condition